Hi, today we are going to learn a new topic in otology. It's Meniere's disease. I'm Dr. Gautam, Assistant Professor in ENT Kshema. So, what is Meniere's disease? It's a disorder of the inner ear where the endolymphatic sac is distended. It is characterized by a triad of symptoms that includes vertigo, sudden sensorineural hearing loss, tinnitus, and oral fullness. So, the pathology of Meniere's disease goes like this. There is distension or dilatation of the endolymphatic system, mainly affecting the cochlear duct and the saccule, and to a lesser extent, it may involve even the utricle and semicircular canal. So, what happens is the cochlear duct, which is nothing but the scala media, the saccule, and endolymphatic duct distends. Along with this, there may be a minor distension of the utricle and semicircular canal. So in the first picture A, you can see a normal cochlea, cross section of the cochlea. You can see above the scala vestibuli, in the middle the scala media, and in below the scala tympani. The red line running is the Reisner's membrane. If you come to the second picture, it's very clear that the Reisner's membrane is bulged out. So, Meniere's disease is also known as endolymphatic hydrops. Hydrops means the swelling. Okay. So, in this condition, the scala media or the cochlear duct distance, uh, this will push the Reisner's membrane outwards into the scala vestibula, which is seen clearly in the picture. Uh, so that's the pathology. Okay, the distension of the scala media into the scala vestibuli, or the dilatation of the scala media. So again, here in this picture, the first picture shows a normal cochlea, showing all the membranous semicircular canal, utricle, saccule, and the cochlea. The second picture, you can clearly see that there's a dilatation of the membranous cochlea, the saccule. In fact, the saccule is distended so much that it is pressing against the footplate of the stapes. Also, you can see dilatation of the utricle to some certain extent. Uh, yeah, endolymphatic sac should have been dilated, but it's not in this case. Okay, coming to the etiology, there are two possibilities. One is increased production, another one is decreased absorption of the endolymph. Okay, increased production may be due to viral etiology, autoimmune, hypothyroidism, sodium and water retention, or allergy, or even vasomotor disturbance. Decreased absorption may be due to any defect in the endolymphatic sac. So all these conditions may lead to uh, high drops. Okay, and now to the clinical features. It's seen mainly in the age group of 35 to 60 years. Males are more commonly affected than females. The cardinal symptoms include, as I said, it includes a triad of episodic vertigo, that is a periodic episodic rotatory vertigo or dizziness, again fluctuating progressive low frequency hearing loss, tinnitus, and certain extent you can get fullness in the ear. So vertigo, as I said, it comes in attacks. It's sudden in onset. Patient gets a feeling of rotation of himself or his environment, like to and fro, up and down movements. Usually the attack is accompanied by nausea and vomiting. Sometimes you can get ataxia and nystagmus. Severe attacks may be accompanied by other symptoms of vagal disturbance such as abdominal cramps, diarrhea, cold sweats, pallor, and bradycardia. Hearing loss, again, hearing loss accompanies vertigo. So this is also episodic. The fluctuating nature of the hearing loss is quite characteristic of Meniere's disease. It's very uncommon in any other disease. Patient may also complain of distorted hearing, and he may have intolerance to loud noise or phonophobia. Okay, when he hears loud noise, he gets really annoyed. Okay, the third feature is tinnitus. Tinnitus is low pitched and roaring type, and aggravated during the aggravated during the vertigo attacks. So the triad includes episodic vertigo, episodic hearing loss, and episodic tinnitus. Okay, tone audiometry. Speech audiometry, speech discrimination will be reduced to approximately 50%. So this makes the patient difficult in hearing others' voice, okay, or understanding the speech. Now, special audiometric test. There are certain tests which pinpoints the etiology into the cochlea. First one is the recruitment. Recruitment, there are two tests. One is ABLB, that is alternate binaural loudness balancing test, and SISI, short increment sensitivity index. So what ABLB is, if you see in this picture, the first one is conductive loss, second is cochlear, and third one is retrocochlear hearing loss. In conductive loss, um, of you can the N denotes normal and D denotes disease size. On the disease side, you can see there is a decrease in 30 decibel. Okay, so when you balance the sound, the 20 decibel on the normal side is equal to 50 on the opposite side. So now if you go on increasing the loudness on the normal side, you make 20 to 30. Similarly, the same amount of increment you get in the disease side. Okay, 30 to 40, here it comes from 70 to 80. So similarly, if you go on increasing by 10 decibels, you will get increases in 10 decibels even on the disease side. Whereas in cochlear type, if you see the graph very carefully, initially there is a difference of 30 decibel, that is normal side 20 is equal to abnormal side 50. But when you increase the normal side by 30, the abnormal side increases by only 5, that it's reaching 55 decibel. Next, if you increase to 40, it will reach only to 60. Finally, at 80 decibel, if you see the normal hearing of 80 decibel is matching with that of the diseased ear. So this principle, where there is abnormal increase in the loudness in the diseased ear, is called as recruitment. Okay, this is very specific to cochlear type of hearing loss. Um, yeah, Meniere's disease is a type of cochlear disease where you get cochlear sensory hearing loss. Okay, CC is another test where you get a score better than 70% in two-thirds of the patient, whereas in retrocochlear diseases, recruitment will be negative, even the CC score will be poor. Okay, next is electrocochleography. All of you know the electric potentials in the cochlea, the summating potentials and action potential. If you see the graph very carefully, the summating potential is only one third of the action potential in a normal individual, whereas in case of Meniere's disease, the summating potential is more than 30% of action potential. So this the SP by AP ratio is greater than 30%. That indicates Meniere's disease. Okay, caloric test uh, will show reduced response on the affected side in 75% of the cases. Often it reveals canal paresis on the affected side, but sometimes directional preponderance on the healthy side, or you can get combination of all these things. Okay. Now glycerol test. All of you know that glycerol is a dehydrating agent. There is increased endolymph in the inner ear. When you give a dehydrating agent, this should improve the symptoms as well as the scores. Okay, so once you give glycerol, there will be an improvement in 10 decibel in two or more adjacent frequencies in pure tone audiometry, or 10% gain in speech discrimination score. This calls the test positive. Okay, there will also be improvement in tinnitus and in the sensation of fullness of the ear. Okay, all those things will reduce. There are certain variants to Meniere's disease. First one is cochlear hydrops or cochlear Meniere's disease. As the name suggests, here the cochlear symptoms are more rare than the vestibular symptoms. So vestibular symptoms takes another few years to appear. The theory is that there may be a block at the level of ductus reunions. This is the duct which connects the cochlea to the saccule. So when there is obstruction here, the hydrops, endolymphatic hydrops, may be limited to the cochlea. So this may explain the cochlear hydrops. Vestibular hydrops, again the patient has more of vestibular symptoms than cochlear symptoms. Again, the third variant is Tumarkin's otolithic crisis or the drop attacks. In this, there is a sudden drop in the drop, okay, or fall of the patient without the patient just collapses on the ground, but without loss of consciousness. Okay, there is no vertigo or fluctuations in the hearing loss. So without any hints, he will just collapse on the floor. So the patient may get a feeling of being pushed onto the ground or polyexed. Mechanism is deformation of the otolithic membrane in the utricle and saccule. All of you know the utricle and saccule is for linear acceleration, and gravity is a linear acceleration. When this mechanism is disturbed, the anti-gravity muscles cease to contract and patient may suddenly collapse. The treatment is basically divided into medical as well as surgical. Okay, medical again I have divided into general measures, management of acute and management of chronic patients. Okay, in general measures, reassurance is very important, cessation of smoking and low salt diet. Uh, these are very important things which you have to explain to the patient, and also you have to explain the patient to avoid excessive intake of water and avoid overindulgence in coffee, tea, and alcohol. So avoid stress and bring change in lifestyle. Mental relaxation is important. Avoid activities requiring physical balances involving including flying, underwater diving, or even working at great heights. Next, coming to the management of acute attacks. So patient is having severe nausea, vomiting, vertigo, hearing loss, tinnitus, everything. So most important thing is reassuring the patient and giving him bed rest. You have to give vestibular sedatives to relieve the patient of the vertigo. Usually we give IV because patient may be having severe vomiting and oral administration may be difficult. The drugs used are promethazine, dimenhydrinate, and prochlorperazines. Okay, diazepam may also act as a global suppressant, so 5 to 10 mg may be given IV here. Vasodilators like inhalation of carbogen and histamine drip may increase the blood flow into the vestibule and relieve the patient of symptoms, but these are mainly supportive. Next, coming to the chronic phase, the patient is having mild amount of giddiness, imbalance, but no vomiting or vertigo. In such cases, you may have to give him oral vestibular sedatives, including PCP, that is prochlorperazines, and vasodilators, nicotinic acid. Diuretics to reduce the tension in the inner ear. So furosemide 40 mg. When you give furosemide, you may have to give potassium supplements because it even potassium is excreted in urine in furosemide, or sometimes you can use potassium sparing diuretics also. Okay, propanthyl bromide 15 mg can be given alone or in combination with other vasodilators. If the etiology is due to any allergen, you should try to find out the allergen and avoid it. Hormones and other things, hormones, if there is any it's endocrinal disorders, it has to be identified and treated appropriately. Next is intratympanic gentamicin therapy. So what is the role of this antibiotic in Meniere's disease? It's not an infection. Why do we give gentamicin then? All of you know that gentamicin belongs to aminoglycoside and it has got ototoxic property. So what we do is we puncture the tympanic membrane by do a myringotomy, or with the needle you just anesthetize the external auditory canal and just puncture the tympanic membrane, inject some amount of gentamicin into the mid layer. Now the gentamicin in the mid layer will be absorbed through the round window and it will cause ototoxicity. This is basically helpful in patients with already there is a severe sensorineural hearing loss which cannot be corrected even with conventional hearing aids. In such patients, we can try intratympanic gentamicin for intractable vertigo and nausea, vomiting. Okay. So this is not usually tried when we have a good cochlear reserve. When the hearing is good, we don't do this. Surgical treatment, again, surgery may be conservative or destructive. So the conservative surgeries are decompression of the endolymphatic sac or endolymphatic sac decompression. Um, Second one is endolymphatic shunt operation. You create a shunt between the endolymph uh, and CSF. That's endolymphatic shunt operations. Sacculotomy, where you puncture the saccule through a needle through the footplate of stapes. You know the saccule is bulged against the footplate. I showed you it in the picture. You just have to puncture. This is called as fix operation. There's one more method, that is Cody's tack procedure, where you puncture the saccule and put a steel tack so that there is periodic decompression of the saccule when it gets distended. Okay. The other options are a section of the vestibular nerve. So when here we are not going to disturb the hearing mechanism, only the vestibular nerve is sectioned. Again, ultrasonic destruction of the vestibular labyrinth can be done. So these are all the conservative procedures. Now the destructive procedures, what we do is when there is severe vertigo and symptoms which is not relieved on medical management, you can go for destructive procedure. Or even when there is again cochlear loss, there is no hearing at all, only the labyrinth is giving problem to him, uh, like vertigo and tinnitus is severe, then you can try destructive procedure. The procedure is labyrinthectomy, where the entire membranous labyrinth is drilled and destroyed. Um, you have to do a myringotomy and grommet has to be inserted. Now there is a device called as Meniere's device, which is kept in the external auditory canal, and this will deliver pressure into the ear. Now the pressure is transmitted from the external ear to the middle ear through the grommet, and from the grommet it is transferred into the inner ear through the round window. So this will decompress the endolymphatic system or the cochlear duct and relieve the patient of symptoms. That's called as intermittent low pressure pulse therapy. Otherwise it's known as Meniere's device. So that's about Meniere's disease. This is a very important topic for your exams. So yeah, read about the topic. Yeah, thank you.